So the underlying theme that I come back with after 5 years of research and looking at this was the pelvis was essentially really important. And believe it or not, as an osteopath, we spent a lot of time looking at iliosacral and sacroiliac movement, and it was almost something that I sort of pushed away and pushed to the side as I got into my sort of treatment plan over the years. And I find myself coming back to understand it a little bit better now. And fundamentally, it comes down to 3 parameters. And if we look at a morphological parameter around the pelvis, we have what's called the angle of pelvic incidence. And that's an angle basically is taken from the femoral head, drawn at a perpendicular line onto the sacral base. And you and me are both sitting here, Stephen, so we've walked in, we've sat down to do that. We've had to flex our knees, flex our hips, flex our spine, but our pelvic incidence angle has remained constant. Okay, when we reach skeletal maturity, that doesn't change. What does change is our pelvic tilt. Slope angles. Those are more functional parameters. So what I've found over the years with working and research is those particularly stiff, restricted hips, because perhaps coxa profunda or osteoarthritis, okay, they lack the ability to active posterior pelvic tilt. And if we can encourage patients and teach them and educate them through hands-on manipulation to exercise bias, then we give them a coping mechanism to reduce some of that hip pain. Likewise, if we go the other way and we think about your dysplastic patients, they are more comfortable in a more anterior pelvic tilt position because essentially that acetabular overcoverage is giving them more stability around that hip. So some of the exercises, some of the treatment we would apply to a dancer, for example, who's highly mobile, compared to a runner who just moves predominantly in a sagittal plane. Okay, we would find you'd find it be a slightly different approach, a slightly different tailored approach to treatment and managing.